Hi everyone. Take a 1 second. If I ask you right now, what does autism look like? What image comes to your mind? A quiet child who doesn't talk, or someone who does not make eye contact, or someone who's exceptionally gifted? Okay, so none of that is wrong, but none of that is the complete picture either. And if you are going to sit for the QSPS exam, you need the complete picture. So let's get into it. Welcome to Behavior Canvas. I am Reema and we are going to start the domain 1 of QASP-S domain 1 Autism Core Knowledge. So here we will discuss the definition, the DSM-5 criteria, history and characteristics. One second. Characteristics and milestones. Let's see how much we can cover in this session. So according to DSM-5, according to DSM-5, one second. Yeah. So according to DSM-5, it is a neurodevelopmental condition originating in brain development from early life, even when diagnosis comes later. And the spectrum reflects enormous variability, presentation ability, and support needs. So, what does it mean? It originates in the brain development. For example, if a hmm, for example, let me tell you one more thing. From birth, whether the diagnosis comes at the age of 3 or at the age of 30. So here is something that I want to clear up in your mind right now. ASD does not mean the brain is broken. ASD means this broken works differently, process differently, sees differently, and feels differently. So now for the exam, there are two core domains, domain A and domain B. Persistent deficits in social communication and social interaction across multiple contexts. And the domain B, restrictive repetitive patterns of behavior, interest or activities. So when we talk about the first one, persistent deficits in social communication, social interaction, it means it's same for all places, not just school or not just with stranger, it is across multiple contexts. So there will be deficit in social communication and social interaction. And let's see the RRB. In short form, we call it RRB, restricted repetitive patterns of behavior, interest or activities. So both must be present. Both criteria must be present, but again, there is one more criteria D, functional impairment is also required for the diagnosis. So both, like if you see there is A and B, but you cannot diagnose it as ASD. It will it will require the diagnosis will require the criteria D also. If one is missing, so there will be no diagnosis. So like if you think, but is that enough just do these two domains? So no, criteria D is also required for clinically significant functional impairment. You will see that. So just having characteristic is not enough. There must be the real impact on the person's life. For example, you can remember this. Hmm. So you can remember this by A plus B plus D is equals to ASD. Okay, this is according to the DSM. DSM domain A, domain B, domain criteria D. So this is ASD. So let's talk. Let me ask you something. Let me ask you something. When someone tells you my child is autistic, do you already assume what they will like? For example, that Okay, so that's a assumption. That right there is the biggest clinical mistake you can make. Think about two people. First is 7-year-old boy. uh, the boy has minimally verbally, and fluorescent lights triggers a meltdown for the kid, and he needs a full support for daily living. And there is one more example, second example that I'm going to give you. It's 28-year-old woman. She's a PhD student, the most articulate person in a room. But after every social gathering, 3 days in a bed because masking is that exhausting. And both are autistic. Same diagnosis, same two domains, completely different experiences. That is spectrum. Spectrum reflects enormous variability in presentation, ability, and support needs. So, for the 7-year-old kid, there will be the intensive therapy they will consider. And for the 28-year-old women, there will be the different intervention. I hope this will be clear to you. So, now let's go through the characteristic of the ASD. Let's see the characteristics. So there is, and the characteristics are very important, and not just learn these for the exam, but actually you need to be you need to be aware about these characteristics, because this will help you to work with the child to understand the kid also, or understand the client. So first is social communication, and here is the one, the most people miss this. Perg- uh, Social communication, verbal, non-verbal, pragmatic language differences, back and forth interaction, sharing emotional interest. So there is a deficit in social communication, as we have seen in the core domain A, social deficits in social communication, social definition, social interaction. Okay, let me tell you the what is pragmatic language. So pragmatic language deficits exist across the entire spectrum. Someone can quote an entire book, write a dissertation, have a massive vocabulary, and still not know ki, like when a conversation is over, or when something they said just hurt someone. So but why does this matter clinically? Because if you assume a verbal child does not need social communication target, you will miss the most important intervention entirely. Entirely, you will miss the most important intervention. So there is one more, RRB, which is restrictive, repetitive patterns of behavior, stereotypy, instance of sameness, restricted in sensory and sensory reactivity. So, have you seen a kid playing with toys, but in a strange pattern? For example, the kid is lining the object or stacking the blocks in a different way, or following a pattern. For example, if a child is playing with numbers, so he will place all the numbers color wise, shape wise, or it could be anything. Have you seen a kid doing hand flapping or rocking their body? So these all the things we can say stereotypy, instance of sameness, or restrictive interest and sensory reactivity. So sensory reactivity, hyperactivity, oversensitivity, hyporeactivity, undersensitivity seeking across all modalities. And for hyperactivity, for example, light, sound, texture are always overwhelming for the client. And for the hypoactivity, it means undersensitive. They doesn't feel pain but seek sensation. So both ends Both and same condition but in a different presentation. Same condition but in different presentation. Okay, so next thing we have, this is the example that I told you about the spectrum. Spectrum 1, there is one 7-year-old boy and there is 20-year-old woman. Okay, so this one is the social communication. Oh, we have done this one. Yeah, let's see this one. Play and imagination. There will be limited play. As I told you, there will be some restrictive repetitive patterns of behavior. So child has its own play play style. For example, lining the object or stacking the object, or it could be anything, shape and size, could be anything, could be anything. So they prefer solitary or repetitive activity over a cooperative imaginative play. And there is one more, executive function. Executive function includes planning, organization, cognitive flexibility, memory, working memory, and transition. So, this is why transitions are hard because of the executive functioning. And this, so sorry, just a second. Yeah. So, and this is why the transition are hard, why unexpected changes feels catastrophic for the client, and this is not a defiance, this is all neurology. Okay. Next one is joint attention. Joint attention, for example, let me first tell you IJA and RJA. IJA means initiating, just a second, initiating joint attention, and RJA is joint attention, responding joint attention. My handwriting looks so bad with this. Okay, ठीक है. So next thing that we are going to see, pragmatic language. As I told you, they have the massive vocabulary, but still they don't know how to communicate with others, what to say, what not to say. Social rules of language, basically. Mm, okay. Now let's see the next one. And one more thing, there I have included the exam tip. If you want these notes, I will share the link in the description. So in all domains that you need to know the social skill, deficits in social skill, joint attention, pragmatic language, executive functioning, sensory processing, um, issues. So these all appears in multiple contexts, and these are all in the QSP exam asks for all these things also. So there are two questions. Why pragmatic language deficits particularly clinically significant? So pragmatic language deficits are present across AS entire ASD spectrum, including highly verbal individual. For example, that I gave you the example. Um, the person have massive vocabulary, but still he or she doesn't know how to communicate or what to say or what not to say. And people can have excellent receptive and expressive language, but still significantly impaired in social use of language. Joint attention. What is joint attention? So there are two types of joint attention. One is IJA and there is RJA, responding to joint attention. And what is IJA, initiating joint attention. Let me give you one example of IJA and RJA. Okay, so IJA means something that the child looks at something and then looks at you. For example, there is a mother and there is a kid. And mother is saying, look, butterfly. And child is also saying, butterfly. So this is joint attention, initiating joint attention. And for example, the example of RJA, Child, IJA means child looks at something and then looks at you and then saying, "Whoa, this is butterfly." RJA, responding to joint attention. So if you point something, if you point something balloon, so the child will follow your pointing and gazing. Oh, it's balloon. So this is responding to joint attention. I hope you understand this because my drawing is not good. Okay, so let's go to the history of ASD. So there is Leo Kanner, and then Hans-Berger syndrome, and then the DSM-3 comes on the way, and then DSM-4, and then DSM-5. Okay, let's see this one. So first 1934, 1930, is it 1934 or I made, oh yeah, now 1934. So in 1934, Baltimore Leo Kanner gave the first clinical description, describe 11 children, socially withdrawal, instance of sameness and echolalia. The first time the word autism enters in the clinical world. First time. Okay. And then in 1944, Hans Berger, on his name, the term Asperger syndrome came to this field, came to the study. So this talk about, and he calls them a little professor, the someone who is average or above average IQ but no language delay. Significant social difficulties can be present and restricted interest also. And then there is 1980, DSM-5 came to this field, first formal DSM category, where they talk about the infantile autism, and they gives us five category, which we call which we used to call autistic. And then 1994 DSM-4, and the five categories, they named all these five categories. Or one second. Autism disorder, Asperger syndrome, PDD, NOS, Rett syndrome, childhood disintegrative and disintegrative, childhood disintegrative, CDD. This is we call CDD. What does it mean, PDD? So I can write here, PDD-NOS means pervasive developmental disorder. NOS means not otherwise specified. Not otherwise specified. Okay. And in 2013, DSM-5 DSM-5 included all these five category in one umbrella, and we call it ASD, and there are three severity level. And in this category, Rett syndrome has been removed because of MECP2 is a gene. It's a what do we call, it's a gene mutation was identified, so that's why they removed the Rett syndrome. And they showed the Asperger syndrome ASD level 1 or 2 and PDDS level 1 or 2 again. So we will discuss it later in proper way, detailed way. So this is an exam tip. All five categories mentioned in the DSM-4 in 2013 version, DSM-5 merged it merger every category that has been mentioned here. PDD and NOS catch all the things, and Rett syndrome has been removed because of the mutation, gene mutation, and then the Asperger syndrome. Now it's level 1 and level 2. And there are two practical practice question: list of all five DSM-5 ASD criteria: autistic disorder, Asperger syndrome, PDD, NOS, Rett syndrome, and CDD, childhood disintegrative disorder, CDD. And why was Rett syndrome removed from the ASD criteria in the DSM-5? Because of the gene mutation was identified as its specific cause and making it distinct genetic condition, not a behavioral defined ASD category. So that's why they removed Rett syndrome. And there is one more question: a client has old record saying PDD, NOS. What diagnosis would they receive or now? So they will receive the Autism Spectrum Disorder level 1 or level 2 under the DSM-5. Okay. As I told you, this one, PDD. PDD-NOS is equals to level 1 or level 2. That's why diagnose they diagnosis that client under the DSM-5 criteria, Autism Spectrum Disorder level 1 or level 2. Okay. So we have completed the core domains and the characteristics and the history of ASD. Let's see the triad of primary impairment. Triad of primary impairment. So this is given by Laura Wing in 1979. First is social interaction, second social communication, and third is social imagination. This is very interesting. I love this topic. Uh, okay, so in social communication, just a second, I think I missed something. Did I miss something? No, I think no. Okay. So, यहाँ पे like we have a social interaction. So, in this social interaction, deficits in two ways: verbal and non-verbal context, verbal and non-verbal context in social in this, and this will in this has been mentioned in criteria A, social communication. The same thing mentioned in criteria A, deficits in verbal and non-verbal communication in social context. This is criteria A, not B. Okay, and this is social imagination, deficits in flexible thinking, pretend play, and fetter play, theory of mind. So this comes in category B. Gemini made a mistake. Okay, that's fine. Okay, so social imagination means if we talk about if we ask the child to play with the toy. For example, there is a pen, and if like usually kids loves to do pretend play. They will hold a pencil and they will make that pencil like a car, and they will play with that pencil as a car. So in ASD kids, it's difficult to do the pretend play. This is why we call social imagination, deficits in flexible thinking and pretend play, and free play also. And again, theory of mind is all it's is a different topic. So exam tip: you should know all three triad point: communication plus interaction is equals to criteria A. It will comes in criteria, and imagination is in comes in criteria B because of RRB. That's why the child is not able to do the pretend play, free play, because the child have the rigidness or restrictive interest to the for the object or for anything. Theory of mind is theory of mind means ability to understand others have different thoughts of belief. For example, in simple way we can say perspective taking. Okay, so we have two questions here. Who proposed the triad of primary impairment, and in which year? In what year? Lorna Wing in 1979. How does social imagination from the triad related to the DSM-5 and uh, criteria B? As I told you, social imagination impairment, inflexibility, restrictive interest with difficulty with theory of mind, and criteria B is all about RRB, restrictive repetitive patterns and patterns of behavior and interest. Let's see the red flags. And we are not going to talk about the red flags. These are the red flags for early diagnosis. So early diagnosis, red flags. So as you can see this table, let's build the timeline up. So 6 months, no social smiling, no response to caregiver face. 9 months, no shared vocalization, no social groups like peekaboo. 12 months, no consistent name response, no gesture, no joint attention. Joint attention we have seen the IJA and RJA. 16 month 16 month, no single word, no declarative pointing, and 19 months and 18 months, no pretend play, no imitation of others, and no two words meaningful phrases. 24 months, critical red flag, no joint attention, limited pair interest. Like 2-year-old kid can play, like um, 2-year old kid do so many things, but if he or she has no joint attention, no name response, no pointing, no vocals, so this is a clear red flag. And it and any age regression or loss of previously acquired language or social skill, most of the cases, I'm working since 2021. I have seen many kids who used to talk a lot, but after lockdown or after some period of time, they lost everything. It's all regression. Then they regression and loss of previously acquired language or social skill, that can be the red flag also. Okay, so I hope this is clear to you. And most important thing, there is declarative and imperative pointing. Declarative and imperative pointing. So imperative means I want, means request, pointing to request. I want that candy, or I want that toy, or and in declarative means the pointing to share. Look at that. Mama, look at that toy. Mama, look at that airplane. And mama, look at that star. It's shining a lot. So this is declarative pointing. The child is declaring something, and that requires a social motivation. And in imperative pointing, it can develop without social motivation, because there is a internal desire to have that stuff or have that toy, or it could be anything for that client or for that kid. And these are the most sensitive early ASE indicator. So for the red flags, you need to be very um aware of this. So 12 months, no name, no babble, no gestures, no joint attention. 16 month, no words. For 24 months, no phrases. Declarative means declarative and impairment imperative pointing, more sensitive indicator, and any regression at any age, immediate referral. And declarative if we when I was learning this, one question was triggering me a lot, which is more sensitive ASD indicator. So this is declarative. Why? Because it's revealed does a child wants to share something with me or not, and is there any drive to connect. So that's the piece that affected first. So this is why. So we have two questions here, three questions here. What are the two most critical language red flags at what ages? For 16 months, no single words, and then the no two word meaningful phrases by 12 months. And the second question, why is declarative pointing a more sensitive ASD indicator than imperative pointing? So declarative pointing, as I told you, requires a social motivation, the desire to share an experience for its own sake, and imperative pointing serves a functional goal, getting something or can develop without this social motivation. I hope you got it. Okay. A 2-year-old boy had 15 words, now has 4. What action should be taken? It's a clear regression case. It's a clear regression case. Immediate referral should be if immediate referral should be there for comprehensive evaluation, because in any age regression can happen, and it's a always a red flag. Okay, let's see the DSM-5 criteria. It is very important. Okay, so we have the criteria, DSM-5 criteria. So in DSM-5 criteria, we have criteria A, criteria B, C, D, and E. So in social communication, all three areas, emotional reciprocation, non-verbal communication, developing, maintaining relationships, persistent across multiple context. So when we talk about the criteria A, okay, so criteria A, like all three should be present. If we miss something, that criteria not meet, so we cannot diagnose. So first is social emotional reciprocity. Social emotional reciprocity require back and forth communication, or sharing emotional experience, or sharing emotions and experience. And second is non-verbal communication. It require non-verbal communication shows the deficits in eye contact or expression or sharing. And the developing maintaining relationship means understanding relationship difficulty. So all three are very important. Okay. And RRB at least two of four should be present for the diagnosis. Stereotypy automatic reinforcement. Stereotypy that can include repetitive motors or vocal patterns. What maintain is automatic reinforcement. Sensory consequence that we call it. And instance of sameness. Second one is instance of sameness. Again, the same routine, rigid routine, and even small changes can cause a distress to the client. And the third one, restricted interest. Restricted interest means fixed interest. Fixed interest, abnormally intensity or focus. For example, if the child loves to see the dinosaur only, so there will be the difficulty to make the change in that particular particular episode. So this is fixated interest. And fourth one is sensory hypo and hyper reactivity. Again, since we have discussed this in the previous one, symptoms must be present in early development. Okay, yeah, sorry, this one, early development. The okay, let if I can change it, I will change this. So PP, I will make this make some changes in the PPT. It's all, I think in Canva, it's all change the places. Okay, let's see the early diagnosis. Early development. So in some symptoms present in early development, not necessary early, but diagnosis should be there. Masking delay recognition, but does not invalidate early symptoms presence. And impairment, we have discussed clinically significant impairment in social, occupational, or other current areas of functioning. Mass impaired still counts. And differentials, not better explained in not better explained by ID, GDD, ASD-ID can co-occur if social deficits exceeds what ID alone predicts. What is ID? Intellectual disability. What is GDD? Gross developmental disability. Okay, so one second. Hmm. Let me tell you this one also. First, let me tell you this one. OCD versus ASD ritual, and then we'll do the levels of severity. So, OCD, dystonic. Ego dystonic means unwanted, distressing. The person does not want to do it. I don't want to do, but I can't stop. This is an example. Intrusive, unwanted, distressing. A person is compelled against their will. The person is saying, I don't want to do, but still he or she cannot stop. And ASD ritual means ego syntonic, preferred, comforting, part of identity. Part of person I don't identity means I enjoy this thing, please don't take it away. And why does this why does this change the intervention? You should know this. So enormously treating unwanted or intrusive behavior is completely different from treating preferred one. Comforting behavior that serves a sensory need, don't treat both the same way, because there is a intrusive behavior which is completely different from treating preferred behavior. So the intervention should be according to the problem. So criteria A, all three areas, and criteria B, at least 2 of 4. C, present early, not early diagnosis. And D is impairment. And E shows the deficit exceeds ID level, severity applied separately to A and B. I hope the criteria has been clear to you. You understood these criterias. Let's see the levels of severity. So we have the levels of severity. Level 1 is support. If the child is saying, for example, in social communication area, full sentences can initiate difficulty with inflexibility. And RRB, in RRB, restrictive causes interference in one plus context. Okay. So, what are we going to do? What are we doing? Severity level. And level 2 is substantial, simple sentences, visible nonverbal deficits, marked distress. Just a second. Can I change this one? No, I cannot make changes. Okay, no worries. Let's continue this. Obvious, obvious to observer affects multiple setting. Level 2, where the child needs a proper support because there is no simple sentences, no the child is the child has no vocals, no verbal. There is deficits in, and it can create a distress. So we need to work on that. And the level 3, very substantial. For example, so in this case the social communication should, maybe the kid or client has no words, rarely initiate extreme distress. Extreme distress means there can be the s- sensories or behavioral issues that can create extreme stress in our areas, significantly impacting. So level 3 require the intensive therapy or intensive care. And in level 1, the minimal support can be done, like minimal support can work. Okay, so it's all done. We have completed the history, the severity, the criterias. Now let's see the risk factor. Okay, let's do this one. I will try to complete this domain. It's almost complete. Only few things are left. Okay, so risk factor. Risk factor CDC 2018 statistics we will see, and ASD and SCD. SCD I will tell you later. What is SCD? Okay, so risk factor. Um, okay, let's build a timeline, huh? Okay, let me ask you something. If a parent comes to you and their 18-month-old is not talking yet, what goes through your mind? So, if anyone absent, there is a red flag. By 16 month, by 12 months, name response, babbling, um, initiating joint attention and responding to joint attention, conventionally gestures should be present, but there is nothing. Anyone absent, there is a flag. By 16 months, single words absent. It's a critical red flag that we have seen in the red flag section. Immediate referral of immediate referrals always. Okay, so now there is one more thing, declarative and imperative pointing. Imperative, that I want, functional, getting something doesn't require social motivation, and these are the things that we have covered. So what are these risk factor? So the strongest factor is twin coordinates in 36 to 95%, sibling risk 10 to 20%, and 100% risk is genes, de novo mutation. So just a second. Yeah, twin concordance. So advanced parental age, parental means, well, just just a second. I think I missed to add something here. Uh, Let me write here only. Okay, so For example, if like in especially paternal side, so there is a de novo mutation accumulates in sperms with age, but there is a valporate exposure. Valporate exposure means in the first trimester, the viral infection or premature birth can create that that can create that risk. And in and in male, four times more frequent, but females under identified due to the masking or camouflaging. So this is the risk factor. And there is one more thing that you should know: vaccine does not cause ASD. Like few months back, I saw an interview of Trump that, and there he was saying the paracetamol tablets can cause ASD. It's all bullshit. It's not true. So in Wakefield 1988 paper was fraudulent, data fabricated, Lancet retracted in 2008 2010. Wakefield struck off medical registrar, multiple large studies across millions of children confirm no link between any vaccine and ASD. Okay, so we have this one. So Wakefield lost his medical license because of this. Studies across millions of children, there is no link. Like there is no link between the vaccine and the ASD. So families will ask you, for example, if the family will ask you if like any medication can cause ASD, so you your answer needs to be clear and compassionate, but not hedge-hated. So in CDC 2018, okay, it's a overall prevalence, huh? In CDC 2018, 1 in 59 kids, there is one kid is ASD. In male, 1 in 35, 1 in 38, and in female, 1 in 152. So this is the ratio. And sex ratio, male is 4 more times frequent. ASD plus ID, 1 in 3 also have ID. All groups, ASD across occurs all ASD occurs across all racial, ethnic, social, economic groups. Rising rate, broader criteria, better identification, not a biological, increases. So females significantly under-identify because of the masking or camouflaging, as we have seen here in this line. So yeah, we have cleared the. You just need to see this data also. And we have the, I think, 2023 or something. We have the latest CDC statistics. I will add that in the description. I will add that because in this PPT I forgot to add. Okay, so we have ASD social. Oh, what is SCD? Social communication disorder. So in ASD we have RRBs, but in social communication we don't have RRBs. In social communication deficits only, in SCD, social communication deficits only, no restrictive repetitive patterns behavior. And in ASD, social communication deficits plus RRB, criteria A and criteria B both present. Criteria B is only the distinguish features between the ASD. Criteria B includes RRB. Okay, one more example. Genetic strongest risk factor, vaccine no link. CDC 2020, 2018 data says 1 in 59 overall male, 4 times. 1 in 3 always have ID, and SCD has no R. Just a second, my pen is not working again. Okay, yeah. SCD has no RRBs. SCD has no RRBs. ASD has communication RRB, communication deficits, and RRB and criteria B only differences. I hope this is clear to you. So, what is the strongest established risk factor of ASD? Genetic factor. Twin coordinates 36 to 95% in identical twins provide the strongest evidence. What is 2018 CDC prevalence rate for ASD? 1 in 59 individual, overall 1 in 38 males and 1 in 152 females. What is the single distinguishing features between ASD? Criteria B only. Okay. SCD has no RRB and ASD has RRB. ASD has both. What parental medication is associated with elevated ASD risk? Valporate, valporic acid, used for epilepsy and bipolar disorder. Let's see this one. Serial and parallel processing. Serial and parallel processing. Let's do this one. Okay. So feature is mechanism, multiple streams simultaneously and automatic parallel processing. It's a neurotypical neurotypical and in serial processing in common in ASD. So one stream at a time, sequential, deliberate, social impact, social navigation, effortless and automatic. And in ASD kids, the timeline exhausting and error prone. Strength, broad and simultaneous awareness. Broad and simultaneous awareness in neurotypical children. And in ASD, it's exceptionally depth, detail, and pattern recognition. Teaching implication, standard multi-steps instruction that we can do with the neurotypical children, but with ASD, one step at a time, visual supports and processing time, reduce stimuli. So in with ASD kids, we need to teach one step at a time. We need support of visual supports. We take supports of visual supports, processing time, and reduce stimuli. I hope this is clear. It's not much. Serial at one at a time, ASD. Parallel simultaneously in neurotypical. Serial explains social challenges and exceptional depth and detail strength. Teach one step at a time. Visual supports we can use processing time, reducing competing stimuli. So there is one question: how does serial processing explain social challenges in ASD? So social situation require real-time paralleling processing of multiple channels simultaneously. Face, words, tone, body language. The normal kid can do all these things, but when we talk about ASD, so that creates a time lag. By the time one channel is processed, the social movement has passed. What are four instruction implication of serial processing? Okay, so one step at a time, using a visual support, allowing processing time, reduce competing sensory stimuli, break task into sequential step, no simultaneous task demand. If you are working as a behavior practitioner, so you should know all these things. Maybe you know all these things. Okay, let's see the comorbidities, diagnostic tools, and developmental milestones. So we have ADHD, 30 to 50%, most common and neurodevelopmental comorbiditive comorbidity. DSM-5 allows it to, just a second. Huh. DSM-5 allows dual diagnosis, but DSM-4 did not. Anxiety disorder, 40 to 60%. We can see um, atypical presentation in ASD, for example, rigidity, exhalation, somatic complaints, not verbalized worry, but it shows anxiety. OCD, ego diagnostic, we have discussed is um, in few slides back. We have discussed this. Distressing, unwanted, like for example, the individual will say, I don't want, but I can't stop. So this is ego dystonic. And ASD ritual, ego syntonic, preferred. Like I want this. Epilepsy, 20 to 30%, 1 to 2% in general population. Behavioral changes may signal seizure activities. Depression, especially in masking adolescents, adults, autistic burnout closely linked. Sleep disorder up to 80%, worsens sensory regulation, behavior, attention, learning, and always address. GI issue. GI issue. What does it mean? GI. GI. Oh, I forgot. Oh, oh. GI. Guess. Uh, Wait. I'll tell you. GI. Gastric something. Oh, yeah. Gastrointestinal. One second. Let me write. Is GI. It's all about discomfort and in a non-verbal individual may present as challenging behavior. Always rule out the medical issues. So, and GI issues are highly prevalent in individual with ASD. And study says 46% to 84% in children it is the they have gastrointestinal issues. Okay, so we have the diagnostic tools here. Yeah, it's all done. We have covered almost. I'm happy. Okay, diagnostic tool. Let's see, diagnostic tool, a DOS. It's a gold standard tool. And if you have the ADOS certification, you can do that. Without certification, you cannot perform this assessment. ADOS 2 is gold standard tool. ADOS. uh, ADOS is a gold standard tool. Structural observation assessment and 5 modules are there that can help you to assess from toddler to adults. ADAI, sorry, ADIR. ADIR is a again it's a diagnostic tool. Standardized caregiving interviewer. It's a interviewer questionnaire, and it includes a developmental history, a DOS 2 also, plus ADR, AD, ADIR. ADIR is the most comprehensive test. Okay, let me write here a DOS full form. Autism Diagnostic Observational Observation Schedule. And the IDR is, yeah, I can write here. IDR, Autism Diagnostic Interview Revised. These two are the most comprehensive. And there is cards too. Checklist for checklist for just a second, let me write. Not checklist, it's a childhood autism rating scale. Childhood autism rating scale. So in this rating scale we have 14 domains, and you can and in schools in schools or in hospital setting, they professional use this assessment. Even I have used this most of the time. So we have, like, in this one in this cars, we have few domains like communication, social skills, and sensory responses. So we have some domains here. MChat. MChat, it's a screener only. It's not a diagnostic tool, or it's not a questionnaire. It's a screening tool, and it we can use MChat assessment with the age of 16 months to 30 months, and it's for evaluation, not for diagnosis. MChat MChat, where I can write MChat. Just a second. Let me just erase this. Mhm. Modified checklist for autism in toddler, revised. MChat RF. Okay. SCQ. What is SCQ? SCQ is a screening tool, and it has 40 items, and it's a parent tool, parent, just a second. It's a parent report tool, and it's not like we can use for evaluation, but not for diagnosis. SCQ, yeah, full form. Social Communication Questionnaire. It has 40 items. Yes or no? We used to ask from parents about yes or no. Okay, and there is a time limit in this test. The time limit is it should be complete in less than 10 minutes. Winland VSMS. Vinland Social Maturity Scale. So it shows adaptive behavior, and it's not ASD specific, but it can help us to the identify the identify so many things, like identify the causes or identify the like how can I say, one second, just a second, let me just check because I wouldn't be wrong. Yeah, so VSMS is a psychological assessment tool which is designed to measure which is designed to measure the social competence, adaptive behavior, and maturity in children. And the scale is used up to 50 15 years, so up to 15 years old kids. And it can help us to evaluate communications, self-help skills, socialization, so that we can calculate the social age and the social questions. Okay, we have covered this. So, acha, yeah, this is the milestone that was a red flag. 6 to 9 months, social smile, name response begins, babbling and peekaboo. 12 months, name responses, babbling, IJA, RJA, conventional gestures, all should be present. 16 month, single word, single word absent, critical red flag, two word meaningful phrases, present phrases should be there. 24 months, oh, 24 months, two words aega, like two words. And in 3 to 4 years of age, the theory of mind should be present. Like child should ask the why question, cooperative play should be there, and in any age the regression one. So it's all done. ADOS 2, as I told you, it's a gold standard diagnostic tool. MChat and plus SCQ is a screening tool only. And the OCD, ego diagnostic, ASD, syntonic, epilepsy 20 to 30%, sleep up to 80%. We have discussed all these things. Always rule out in epilepsy, yeah, always ruled out the medical cause for behavioral changes that can create disturbance in their sleep and in their routine also. So, what is the difference between the screener and diagnostic instrument? So, screener MCHAT and MCS social communication questionnaire identify who needs further evaluation. Positive result does not equal diagnosis, and diagnosis instrument, a DOS or ADIR2, ADIR establishes supports a diagnostic administered by trained clinicians. Question 2, a child score positive on MCHAT RF, what should happen next? So, referral for comprehensive evaluation, not a diagnosis. The MCHAT is a screener tool only. It's a screener only. Question third, why is it clinically important to know the anxiety in ASD, often atypical anxiety? Because clinicians looking for the verbalized worry will miss anxiety presenting an increased rigidity in behavior escalation or somatic complaints leading to the misdiagnosis and inappropriate or absent treatment. Why must GI issue can be considered in behavior analysis? So GI discomforts in non-verbal or minimal verbal individual cannot be ca- communicate properly. So may present as a challenging behavior that includes aggression, self-injuries, withdrawal, and failing to rule out medical causes means treating the okay. Hmm. Means and failing to rule out the medical causes that can that means treating the symptoms while the underlying cause go on goes unaddressed. So I hope all these things have been clear to you. If you like this episode of QSPS series, and in this video we have covered the complete domain 1. We have completed what is ASD, DSM-5 criteria, history, tools, red flags. We have covered everything. If you like this video, please do like, share, and subscribe. I hope you enjoyed this. I tried to make all these notes very exam oriented. And yeah, if you like this video, please do share and subscribe my channel. If you have any doubt, please do please let me know in the comment section. I will surely make the video of it. And yeah, remember what I asked at the very start: what does autism look like? Has your pictures changed? I hope it has. So because this domain, it's not just for the exam. It's so it's so that when you get into this field, you become the practitioner who actually sees, who does not assume, who treats a spectrum like a spectrum it is. So drop your questions in the comments below. Like this video if it helps you. See you in domain 2, professional legal and ethical practices. Let's keep going. Bye bye. Happy learning.